Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Hi, this is Jason Edwards, and I'm here for another episode of Doc Discussions with my good friend, Dr. Nanette Wendel. Dr. Wendel is the head of the Women's Center. Her technical title is Medical Director. Nanette, welcome.
Thank you.
How are you doing this afternoon?
Oh, fantastic.
You know, I kind of wanted to actually go back in time and start from the beginning of your post-high school education. Where did you do your undergraduate at?
University of Michigan.
Very good, very good. That's one of the public Ivies, they say.
You're asking me to dust off some cobwebs here.
I think it's Michigan, Virginia, North Carolina are supposed to always at the top of the public schools nationwide. And then where did you go to medical school at?
Northwestern University in Chicago.
Very good. Did you have a good experience there?
Oh, I had a wonderful time. Probably too good a time.
Now, are you originally from Chicago?
Yes.
Okay,
yes,
very
born
good.
And raised.
So you came back home.
Yes, definitely came back home.
And then where did you do your surgery residency after medical school?
Northwestern, and then part of it at University of Nebraska.
How about that? How did that work out?
Northwestern, back in those days, there were what we call pyramid programs, where they start off the intern class very large and then pare things down.
Oh, I saw this
bit later
in the show Mad Men,
yes.
where like every year they would have like
they
one less.
Kind of get rid of people.
And that's not how it is today.
No, it is not like that today, but it was in those days. And Northwestern really didn't get rid of people, but what they did was if there were too many, for the next level, they would put you into the laboratory to do research for a year or more.
Got you.
Until they brought you out. And I did not want to do that. I wanted to get on with things. So my good friend who was a chief resident while I was at Northwestern became an attending at Nebraska. He said, "We have an opening, come on over."
How about that?
So, yeah.
And so that was University of Nebraska, Omaha.
Yes.
Okay. Mm-hmm. And Omaha, I've been there. Nice enough place. Not Chicago, but
correct.
And so now, the dynamics have changed with gender and medicine in general, but certainly over time with women in surgery.
Right.
In surgery training and as their post training their occupation, and in the pathway to becoming a breast surgeon is you do general surgery
Correct.
as your residency program. I cannot imagine there were a lot of women in your program.
No.
Were you the only one in your class?
No, in my class, I'd say there were probably 3 of us.
Okay.
But yeah, not many.
Yeah.
And that was probably out of 7 or 8.
Yeah, and general surgery is kind of known as one of the hardest residencies to go through. Every residency has its own.
I'll admit it was brutal. I always say I went into it a nice person and I came out not such a nice person. They change your personality.
For sure. And just the sheer amount of hours and the stress is it's just a lot to carry.
At that time, there weren't shifts or anything like that. I mean, there were some rotations like vascular surgery, cardiac surgery. I would be home 1 night a week.
Yeah.
That was it.
Yeah. You were called a resident because you were
a resident of the
hospital. Yeah.
Yeah.
And so, and it's, I'm sure, no doubt it was extremely difficult to go through that program, but on the backside, I think most people are thankful for going through a difficult program because it does make you a stronger person and physician.
100%.
Yeah. And then did you go to Florida after that?
Yes.
Okay.
Yes. I went to Florida to practice and lived there for 18 years.
Very good. And then you when did you come to St. Luke's here?
It's been 9.5 years already.
9.5 years.
Yeah.
How about that? And so you're the head of our breast program here at St. Luke's. And you treat almost exclusively patients with breast cancer. Is that accurate?
Yeah, we do see some benign disease as well, high risk lesions that may or may not be a breast cancer, lumps and things like that. But the vast majority is breast cancer.
Okay. And you and I, full disclosure, we work together
right.
frequently, which is excellent. And so somebody, the kind of algorithm is somebody comes in for their annual screening mammogram. They see a spot on the mammogram, and then they typically get a diagnostic mammogram and ultrasound. And correct me if I'm wrong, because you're more familiar with that. And then if it continues to be suspicious, they will have a biopsy.
Yes.
And if the biopsy is positive for malignancy or ductal carcinoma in situ, then they see you and you discuss their treatment options at that point.
Correct.
And what are their options as far as surgery?
As far as surgery, the options are lumpectomy, which is what we call breast conservation therapy, where you're only taking out the cancer with hopefully negative margins or edges and saving the breast.
Okay.
That does require generally radiation afterward, but is a very quick recovery. And our other option is mastectomy. That's removal of the entire breast. And what most people don't realize is that basically the survival for both are the same.
Yeah.
And so that's a lot of what I do is education.
Yeah.
People always have something in mind, but my job is to fully educate them and help guide them as to the right procedure.
Yeah. When you say mastectomy, it immediately I thought of our plastic surgeons because a lot of patients, if they do have a mastectomy, will have reconstruction.
Yes.
And I've seen a lot of breast reconstructions at multiple institutions, and I really feel like we have two of the best plastic surgeons around.
100% agree. I tell my patients that because I've been doing this about 30 years. And so I've seen many plastic surgeons in my day and worked with several in my day. These are two of the best I've ever worked with, hands down.
I couldn't agree more. I've seen at multiple universities,
Yep.
big places, and patients from other institutions, and it's a breast reconstruction is different than a breast augmentation.
Yes.
And it's a difficult thing to have a good cosmetic outcome.
Yeah.
But I feel like we're really lucky. And so,
we were very lucky. And the unfortunate thing is that, I don't want to say too much about other places, but the people from other institutions who aren't happy come here.
Yeah.
And, try and do the best we can. But yeah, I've seen a lot as well, and I'm just so thankful for the two we have.
And so those two are Dr. Scott Geiger and Dr. John Holson.
Correct.
And so I'm gonna back up and go kind of to the start of the algorithm. If somebody has a suspicious lesion, roughly what percentage of those, and we're going to biopsy it, roughly what percentage of those biopsies are going to be positive for malignancy?
It's actually lower than you think. Usually about 20%.
Yeah. And so I think that's a really useful number because I've had friends and coworkers who've had suspicious lesions and saying they're going to get a biopsy. And I tell them, odds are it's negative,
Right.
which you think immediately you think if I'm a candidate for a biopsy,
Right.
90% it's going to be positive. And so your mind just goes there, and emotionally it's a very difficult path. And it's good to know that the pretest probability is about 20%. And that's the way we want it. We want to biopsy a lot more patients, that actually have
Right.
cancer.
You have to biopsy that many to catch the 20%.
And so, that gets, so the sensitivity is high.
Yes.
Of the mammogram. Yeah. And so we're going to catch most cancers.
Right.
And for most patients, it's a yearly mammogram that
Correct.
they're getting, correct? And then some patients will be high risk. What are the typical things that puts a patient into the high risk category?
The typical things are family history, strong family history, history of a previous biopsy that was abnormal, say some atypical cells, or what we call, I hate this word, but lobular carcinoma in situ, which is not a cancer; it's high risk. Those are the main factors.
Yeah. Yeah, usually it's a young lady whose mother or aunt or grandmother
Right.
had cancer.
And we do have computer programs where the patients, when they come in for their mammogram annually, they fill out a tablet.
Okay.
And it takes in all the information and goes into, again, an algorithm type software, and then spits out a percentage of what their risk is.
Okay.
So anything above 20% is considered high risk.
Okay.
But it's several factors. At what age you had your first child, if you had children, what age was your first, menstrual cycle, weight, all those sorts of things come into play.
Yeah. Okay. And a lot of that stuff looks at it's just your lifetime estrogen exposure
Right.
is a big piece, because the majority of these tumors are estrogen receptor positive.
Correct. Yeah.
And that's actually a good thing.
Yes, yes.
Patients with an estrogen receptor positive cancer have a better long-term
Yes.
prognosis than those with estrogen receptor negative.
Yep, definitely.
How has the surgery changed over time, whether it's the surgery of the primary breast or lymph node dissection? How has that changed, from the start of your career to now?
Welcome back to Doc Discussions with Dr. Jason Edwards. Medical news you can use, no appointment necessary.
I'm going to date myself, but at the start of my career, we were still doing what we call radical mastectomies. I mean, I was at the very tail end of that era, where the mastectomy took place, but also the muscle was removed all the way down to the ribs. Okay. Very disfiguring, and it was just horrible.
Is
mutilation.
that the Halstead mastectomy?
Yes.
Okay.
And all the lymph nodes were removed. Then it progressed to a mastectomy, and the muscle was preserved. Then over time, it's progressed more and more towards lumpectomy. Because we know the outcomes are just as good. So it's less and less surgery, as well as underneath the arm for the lymph nodes. It was routine up until the late 90s to remove all the lymph nodes from underneath the arm, even if it was a tiny tumor, it didn't matter. But then came along what we call a sentinel lymph node biopsy, where we can pinpoint the first lymph nodes in the chain underneath the arm, and have special techniques for that. And now that's all we remove for the vast majority of cases.
And so the cosmetic outcome of the breast and the rate of lymphedema, which is the swelling of the arm, has gone down
Markedly
dramatically.
Improved. Yeah, everything's improved.
And the cure rates are just as good, but the side effects have gotten less and less.
Right.
So it's been in a way a de-escalation of care with no penalty for the cancer cure rate.
Right.
And so that's been
and we continue as the years go by. Over the past several years, even it's progressing very quickly to where we're finding out we need to do less and less.
Yeah, and I would say that's one of the positives about breast cancer is we have a lot of data, and it's data from different eras and different countries, and that becomes very powerful, just to have these large numbers of patients that you can kind of tease out who needs what and how to treat them, and then some patients, if they have some high risk features, we will order an oncotype test, and that tests the genes of the cancer cells, and that lets the medical oncologist, who's the chemotherapy doctor, decide whether the patient needs chemotherapy after their surgery.
Right. That has really made a big difference, because it used to be you'd look at the pathology, you kind of look at the patient and go, well, I think chemo would benefit you, or I think it might not benefit you, kind of thing.
Yeah.
And now it's based on biology of your tumor and science.
Yeah.
And I think that's been an amazing step forward, because so many people were probably overtreated.
Yeah. It saves people from having to go through chemotherapy.
Yeah, definitely.
And every once in a while, somebody will have pathology that looks, fairly non-aggressive for a cancer, but their oncotype score comes up high. It doesn't happen often, but you get surprised sometimes.
Yes, definitely.
And that data is pretty solid. They came up with the nomogram and or the algorithm with the genes, and then they said this should work like this, and then they tested it again, and found out that it validated the study.
Right.
And so that's been powerful. I think, there's been change up to this point, and, there will continue to be improvements in the care of our patients with breast cancer. But in general, compared to most cancers, they have, relatively speaking, good outcomes as far as cure rate.
Yes.
But breast cancer is the most common cancer in women, and still there's still a lot of breast cancer specific deaths just to the sheer number. Mm-hmm. You said with the high risk patients, if their risk is over 20%, what's the average in America for a woman? Is it 1 in 7, 1 in 8?
1 in 8, yeah. And the 20%, what that means is that is your lifetime risk to age 80.
Okay.
It doesn't accumulate over the years. Actually, if we were to recalculate it over the years, it would probably go down because you have less years ahead of you. Therefore, your risk would probably go down.
Yeah.
But we just do a one-time calculation.
A one-time. And so 1 in 8 is roughly 15%.
Yes.
Ish. And so if they're kind of 5% over the absolute number, 5% over the
right.
Normal, then that puts them at high risk. And then what do you tell patients about breast cancer screening as far as like doing self-exams?
Well, the ideal would be to do a self-breast exam once a month.
Okay.
It's about the same time of the month, especially if you're premenopausal.
And why that? Why the premenopausal?
Because the breast will change at different points in your cycle.
Okay.
And so, you want to pick the same point every month to get a good comparison, because if, say it's a week before your cycle, you start to get a little lumpy and you feel something, well, it may be gone 2 weeks later, sort of thing. So,
yeah. And so the hormones during the cycle can kind of make some of the breast tissue swell and then recede depending on where you're at. Yeah. It can be, I do a fair amount of breast exams in my clinic, and it can be tough as in younger patients, but sometimes too in patients who are postmenopausal, they can just have a lot of lumpy, bumpy breast tissue and kind of active tissue, and a self-breast exam certainly not as good as a mammogram, but it is important. And me and you see cancers every year that the patient actually felt an abnormality. What other symptoms can patients have if they have a breast cancer at initial presentation?
Thickening of the skin, redness of the skin, nipple retraction is another one. Pain. A lot of people come to us for breast pain. That I don't really put into the category.
It's not very specific,
no,
right?
No, it's very non-specific. I can almost never find a reason for their pain. But I just saw something on Facebook the other day that said, these are the things that you should watch for, and pain was one of them, and I just cringed, But
a lot of women have breast pain.
Yeah, breast pain is so common.
You can sleep on your breast wrong and not really realize it, and cause a little bit of trauma.
Right.
And then this once you have pain and you start thinking about cancer, it's hard to get that out of your mind.
Right.
And so it's okay, to go to your primary care physician and get a good exam and get it checked out. It's psychologically, if your mind's kind of gone there, it's probably not going to rein itself back in without some sort of objective evidence.
Yeah, that's true. And
then bloody nipple discharge.
Bloody nipple discharge, yes, another one. Yeah.
That's but the vast majority of breast cancers are detected by the mammograms, the screening mammograms, because they're so good.
Yes.
And they've only gotten better over time. And the radiologists who read those, for the most part, specialize in that area.
Yeah, they're dedicated breast radiologists. Yeah.
And then there's been, to me, it seems like there's been this big push from the community, which is it's a movement really that's pro breast cancer with the breast cancer foundations and the ribbons and stuff like that. And I think that's been a really positive thing to implement screening programs and give financial support.
Right.
Now there's a group that you work with in town. It was called Pink Ribbon Girls, and do they call it Pink Ribbon Good now?
Called Pink Ribbon Good, and the reason behind the change of name was, well, they wanted to keep the G for the logos, but they found that women felt that when you say girls, it was only for younger women.
Okay.
That the organization was only for younger women, and so we felt that we were kind of missing a certain population.
Yeah.
So they felt they had to change that for that reason. But,
Okay.
yeah, it's an amazing organization. It's a nonprofit organization that anyone with breast cancer can be affiliated with. And what they do is they provide meals, rides, transportation to and from treatments, and then some housekeeping supplies and services.
Yeah.
All free of charge.
Yeah, and actually, a lot of my patients with gynecological cancers use their service as well, and so I think that's been a really positive group, and it's kind of a fun group to be a part of. You recently invited me to their gala, and it was beautiful. It was a beautiful venue, and a lot of patient testimonials, which were very moving.
Yeah.
And so thank you for inviting me. That was a lot of fun.
Time. Yep.
But also thank you for your service. With that group, I really I appreciate the group, and I appreciate you volunteering your time for that cause.
Oh, thank you.
Yeah. And so, what other things? What are we missing here? What other things do we need to go over as far as breast cancer or anything else that you'd like to talk about? Have we covered it here? Or?
Well, the main thing for me always is the government gets involved with their task forces trying to change the age of when you should have your mammogram and at what age you should stop having mammograms and things like this. But all of us in the field, no matter where you are in the country, feel that you should start your mammograms at age 40 or younger if you're high risk.
Oh, yeah. So there are different groups and different consortiums that have different recommendations. Now, the American Cancer Society, their recommendation is 40 years, and it has been for a long time. Is that right?
Yes.
And then there is this entity that sprung up, I don't know when and where, called the United States Preventative Task Force. And it's a government agency, correct? Yep. And so, the rule. If a government agent, whatever their name is, they do the opposite of. And so, so typically, their recommendations, no matter what the cancer type, are less aggressive than the surgeons. And the book Freakonomics kind of taught me this lesson, which was halfway written by an economist from University of Chicago, one of your fellow Chicagoans. But it was like, if you understand the incentives, then you can kind of predict behavior.
Right.
And so their incentive is to pay for less mammograms. And so
it's all about money.
And so our good friend Dave Krakovic, God rest his soul, his famous line was, "The answer is money. Now ask me the question."
Exactly.
But their incentive is to spend less money on mammograms, and the American Cancer Society's goal is to pick up breast cancers at an earlier stage to have a higher cure rate. And so. I think definitely 40, and then implementing these high-risk programs can make a big difference too, and give women who kind of have this at top of mind a little bit of peace of mind, knowing that they're getting taken care of with mammograms or even MRIs sometimes. Right,
and that's been another thing that I've seen over the years is in the beginning when we were seeing high-risk patients, our guidelines recommend MRI yearly in between your mammogram. And we had a lot of trouble getting that paid for by the insurance companies, a lot of trouble. And thankfully, we're finding that less and less now, that it's become mainstream that if you are high risk, you get a mammogram, and then 6 months later, you get an MRI, and repeat that cycle throughout your life.
Yeah, and even there was a girl I went to medical school with named Amy Patel, who's big in the breast imaging world, and I think it was her, but or it may not be, but I think I saw it on her Facebook feed where there's been legislation even saying, like it was passed through the government saying the insurance companies have to,
Right.
provide this. And so there's kind of an activist, arm out there as well, trying to make a difference.
Yeah, we found that with whole breast ultrasound, because that is one of the tools that we use for people who have very dense breasts and, don't really need an MRI. And it's whole breast ultrasound. And again, in the beginning, very difficult to have the insurance companies approve that and have it paid for. And now there are laws, and Missouri is one of the states that does have a law stating that, if this is deemed necessary, that it will be paid for.
Yeah, that's great.
Yeah.
That's great. And the ultrasound, all the mammogram, MRI, and ultrasound, they all kind of have different roles. But the ultrasound, is the value of that it shows blood flow? Like if you can see a mass, you can see blood flow in it, or is there some other?
Well, you can see blood flow, but the value is, say if you have a mammogram with dense breasts, all you see is like a white cloud.
Yes.
And you will not be able to pick up anything small. It has to be very large before you can see it. Whereas the ultrasound, if you do whole breast ultrasound, it will pick up the smaller lesions way before your mammogram will.
Okay, so your signal to noise
But
ratio.
the mammogram is still important, and people ask me this all the time, why should I have both? Say you have calcifications, which are these little white dots, calcium that are deposited, you will not see that on anything but mammogram. And that could also be the first sign of breast cancer. So they all go hand in hand. They don't exclude one another.
Yeah, your pleomorphic calcifications, right? So actually, when I see patients for ocular melanoma, which is a rare type of eye cancer that we actually treat a fair amount of here, I need to image their liver every 6 months. And I go back and forth between ultrasound and CT scan and MRI if necessary, because they each kind of have their role there.
Yeah.
And it's just another tool in the toolbox to detect cancers. Well, Nanette, I want to thank you so much for your time and your work. I appreciate you, and our community is indebted for you for the work that you do for our patients with breast cancer. So thanks so much for joining me tonight.
Well, thank you very much. And we thank you as well, because you're our star radiation oncologist. And every day the patients tell me how much they love Dr. Edwards.
You're never as good or as bad as people say you are.
Oh, I think you are.
Thanks so much, Nanette. I appreciate you.
All right. Thank you.
Thank you for joining us for this episode of Doc Discussions with Dr. Jason Edwards. Be sure to check out our other episodes and tell your friends.